Hi everyone, my name is Anna Joan. I am a heart failure and heart transplant attending at Lurie Children's Hospital in Chicago, and today I'm going to be talking about neonatal heart failure. I have no disclosures. My goals today are to go over some basic definitions, think through the etiology of heart failure, the diagnostic approach, management, and talk about outcomes. So there are many definitions of heart failure. Simply put, it's the inability of the heart to meet the metabolic demands of the body. A more comprehensive definition encompasses that it is a syndrome characterized by cardiovascular abnormalities with circulatory, neurohormonal, and molecular derangements with signs and symptoms such as respiratory distress, growth failure, and activity intolerance. This diagram demonstrates the vicious cycle of heart failure, where the body's compensatory mechanisms help maintain blood pressure in the short term, but in the long term, they're maladaptive and make the heart failure worse. So, in response to low cardiac output, the sympathetic nervous system is activated, leading to vasoconstriction of both the arterial system, which causes an increase in blood pressure, and vasoconstriction of the venous system, which increases venous return. The sympathetic nervous system also increases the heart rate. So the body's trying to maintain that equation of cardiac output equals stroke volume times heart rate by increasing preload and stroke volume through the Frank-Starling mechanism and through augmenting heart rate. In addition, the renin-angiotensin-aldosterone system is activated, which also leads to peripheral vasoconstriction, increased renal, sodium, and water reabsorption, and all of this can cause pathological remodeling, which is characterized by progressive LV dilation and worsening function, and the cycle continues, leading to increased cardiac filling pressures and worsening function. The causes of heart failure in neonates differs substantially from those in adults. The etiologies are broad and include both cardiac and non-cardiac causes. I'm not going to review all of these, but just want to highlight some important ones to consider. Primary cardiomyopathy is broken down into different types, and in neonates, the most common is dilated cardiomyopathy, which is characterized by a dilated left ventricle, relatively decreased LV wall thickness, and decreased systolic dysfunction. In terms of inflammatory causes, the most common is myocarditis, which is a lymphocytic infiltration of the myocardium associated with myocyte damage. This can occur following transplacental infection during the third trimester or through a postnatally acquired virus. And infants who acquire myocarditis can have myocardial recovery or go on to develop dilated cardiomyopathy. It's important to assess for metabolic etiologies as they can be reversible, such as disorders of carnitine deficiencies that can improve with supplementation, or certain glycogen storage disorders in which recombinant enzyme therapy is important. Tachyarrhythmias in utero or postnatal that are incessant can lead to decreased cardiac function, which once well controlled can lead to normalization of function over time. And of course, congenital heart disease can lead to cardiac dysfunction, particularly left-sided obstructive lesions. Because of the broad differential, a thorough diagnostic approach is essential in order to guide appropriate treatment. Certainly a complete history, family history, and physical exam is essential, paying particular attention to signs of growth failure, upper and lower extremity blood pressure discrepancies, the presence of a gallop, hepatomegaly, tachypnea, and signs of poor perfusion. In adult heart failure, patients are classified by severity using the New York Heart Association system, and in infants, we use the modified Ross criteria to classify the severity of symptoms. With class 1 being defined as asymptomatic, class 2, patients have mild tachypnea or shortness of breath with feeding. Class 3 symptoms include marked tachypnea with feeding and growth failure, and class 4 symptoms include respiratory distress at rest. These are just some highlights of the investigations to consider with basic initial studies such as a chest x-ray, EKG, and baseline labs, including biomarkers such as B-type natriuretic peptide. If myocarditis is suspected, be sure to include viral PCRs. In neonates, it's important to perform a metabolic workup, including organic acids, carnitine levels, and so on. And in patients with cardiomyopathy, gene panels can be considered. For example, in the case of dilated cardiomyopathy, approximately a third of the time, a pathogenic variant can be identified. In patients presenting with acute decompensated heart failure, it's important to recognize certain clinical patterns, as this will guide your management. First, ask yourself 2 questions. Is there congestion, and is there low perfusion? Infants with congestion present with hepatomegaly and tachypnea. Patients with poor perfusion may have hypotension, tachycardia, a narrow pulse pressure, and cool extremities. Patients who are euvolemic and well perfused are warm and dry, which is the optimal profile. Patients who are congested but have good perfusion are warm and wet. Patients who are congested with poor perfusion are cold and wet, and patients who have poor perfusion and are not congested are cold and dry. Cold and dry is classically thought of as the scariest quadrant because they have low cardiac output and don't have any fluid to diurese off. In a study by Sharon Chen et al., they looked at cath data of pediatric patients listed for heart transplant and broke down the hemodynamic profile into these 4 quadrants and found that patients who were cold and wet actually had the highest risk for death or clinical deterioration. I pulled out the frequencies of presentation of the infants in the cohort, which had about 225 patients under 1 year of age. And interestingly, infants less commonly presented with congestion and were more likely to be warm and dry or cold and dry. Okay, so we're going to keep talking through different classification schemes in heart failure because I think it's important to be aware of the different terminology as it can guide your thinking from a clinical standpoint and also for understanding the literature when they use these different classification schemes to describe patients' clinical status. So we've talked about the New York Heart Association or Ross classification with the symptoms of heart failure. And something a little bit different is the American Heart Association stages of heart failure. This is stage A through D. So stage A patients are patients who are at risk for heart failure. So let's say it's a neonate who has a family history of cardiomyopathy but doesn't have any evidence of disease, then this would be a patient at risk. Stage B is termed pre-heart failure. This could be a patient, let's say, who has left ventricular non-compaction, so an abnormal appearing myocardium, but the ventricle is functioning normally and has good function. They are at risk of heart failure, but they don't have any evidence of heart failure. Stage C is symptomatic heart failure, and this could be patients who have current symptoms of heart failure or at some point had symptoms previously with heart failure. And then stage D is more advanced heart failure, so patients who require ongoing hospitalization for heart failure and are maybe requiring IV support or advanced cardiac therapies. The unique thing about the stages of heart failure is that once you progress forward in a stage, you can never go backwards. So for example, a patient could be considered stage C symptomatic heart failure if they had dilated cardiomyopathy and had symptoms in the past. But they could also be New York Heart Association or Ross classification 1 and asymptomatic with their symptoms of heart failure currently. But since they had symptoms in the past, then they're called stage C. There are 2 other classification schemes in acute decompensated heart failure that I want to go over with you. This is the INTERMACS profile or the PDMACS profile, which INTERMACS is the Interagency Registry for Mechanical Circulatory Support. So basically a registry for patients on ventricular assist devices or VAD support, and PDMACS is the PEDS version of that registry. For patients that are being considered for VAD support, the registry collects data on how sick they are at time of implant, and they call this the INTERMACS profiles. The numbers are 1 through 7, with 1 being the sickest and 7 being less sick patients. A patient with INTERMACS or PDMACS profile 1 is somebody who is in critical cardiogenic shock, so a patient who is quote-unquote crashing and burning. A patient who is INTERMACS 2 is in progressive decline and is sliding on inotropes with worsening end organ function. A patient who's INTERMACS 3 is stable but requires inotropes. and a patient whose Intermax 4 has symptoms of heart failure at rest, but is typically just on oral medications. In pediatrics, our goal with considering VAD support is typically to try and catch them before they become Intermax Profile 1. So usually we consider implant around the time of Intermax 2, so when they're starting to slide on inotropes. This is a relatively newer classification scheme. It comes from the adult literature and is called the SCI classifications of cardiogenic shock. A patient who is SCI stage A is at risk for shock. B is a description of someone with beginning shock. C is classic shock. D, deteriorating. And E is a patient in extremis. They have a table, again, this is for the adult literature, that breaks down the descriptions of the different stages of cardiogenic shock, some physical exam findings that go along with that, biochemical markers, and typical hemodynamics that you see with those stages of cardiogenic shock as a patient may progress. And these SCI classifications are now being applied to infants and children. Dr. Kriti Puri out of Texas Children's made a modified SCI classification for the severity of cardiogenic shock in infants and children. And you can see the description there of the different stages and descriptions of findings in children. And when their team did a single center retrospective review looking at patients in cardiogenic shock and identifying which stage they presented at, they found that the stages of cardiogenic shock correlated with inpatient mortality rates, so similar to the findings of the adult data. So this is an emerging classification scheme that we're going to start using more and more in pediatrics. There's a working group right now working on applying this on a multi-center level and seeing if it correlates with outcomes on a multi-center level. Okay, so we went through a lot of different classification schemes, and how do we put this all together? I like this diagram, which comes from a review article for adult patients with cardiogenic shock, but I still think it's applicable to our patient population. Here at the top, they have the example of acute MI cardiogenic shock, which in the peds world would be similar to a patient who maybe has normal function, but then all of a sudden develops fulminant myocarditis. Another type of patient would be a patient who is just slowly getting worse. So that could be a patient with dilated cardiomyopathy who initially has mildly depressed function that progresses to more severely depressed function with worsening symptoms. Here we break down the clinical classification of shock. This next layer is looking at the AHA stages of heart failure. So if you recall, there's stages A, B, C, D, with C being symptomatic heart failure and D more advanced heart failure. Then there's the New York Heart Association classes of heart failure, and in infants we use the modified Ross classification of heart failure, with 3 being New York Heart Association or Ross class 3 being symptoms with activity, and class 4 being symptoms at rest. And then we get into our Intermax or PDMax profiles, and this is again as patients progress in terms of cardiogenic shock, with class profile 1 being the sickest patients who are crashing and burning. And then we can see how those SCI classifications or in SCI shock stages overlay A through E. And why does this all matter? I find it really helps at the bedside to categorize patients because it really has implications for management and helps create a mental model for the whole team. So that's why I want to make sure you're familiar with them. Okay, so now we'll get into the treatment and management of heart failure. This is that same slide that I showed you before with the vicious cycle of heart failure, but now you can see the drugs and the mechanism of action that they're targeting to treat heart failure, with the goals of medical therapy to decrease our preload through diuretics, increase cardiac contractility through inotropic agents, reduce our afterload through vasodilators, and improve oxygen delivery to the heart. I like this simplified guideline of managing pediatric heart failure from the Canadian guidelines, although it's a bit old, but it starts with the basics, sick or not sick. If patients are clinically stable and there is cardiac dysfunction, then you start with a stepwise introduction of oral heart failure meds, which we'll discuss more in a bit. If they're somewhat sick, then they should be inpatient, started on diuretics, and if they're stable enough, then begin an oral heart failure regimen. And then if they're sick, then these patients will need IV diuretics, an inotropic vasodilator, possibly respiratory support, and if they continue to worsen, they should be considered for mechanical support and heart transplant evaluation. When thinking about acute heart failure management, it's important to go back to basics. The Frank-Starling curve relates the amount of stroke volume achieved for a given end diastolic volume in the ventricle. With more preload, the stroke volume improves, but to a point, where further increases in the end diastolic volume results in overdistension of the sarcomere length and stroke volume falls. So the goal is to bring all patients back to the warm and dry quadrant. Positive inotropic agents, so see letter I, like epinephrine, move patients to a higher ventricular function curve. Vasodilators, like ACE inhibitors, also move patients to improve ventricular function curves while reducing filling pressures. Diuretics relieve congestion and move patients to lower filling pressures but along the same curve. And combinations of drugs can have additive effects on hemodynamics to improve their contractility and stroke volume. Most of the data regarding treatment of heart failure in pediatrics is extrapolated from adult data, including the stepwise approach to introducing medical therapy. As we've talked about, heart failure is associated with chronic activation of the renin-angiotensin-aldosterone system and increased sympathetic drive, and treatment aims to address this chronic activation. So the first-line treatment in a stable chronic patient is usually an ACE inhibitor, followed by beta blockers and aldosterone antagonists, with diuretics as needed throughout to manage fluid overload. In patients with more severe symptoms, they may require inotropes and consideration of mechanical support. I'm not going to discuss all of the medications, but I'm just going to highlight a few considerations in neonates. ACE inhibitors are typically our initial treatment in an oral regimen, and data is lacking in peds and certainly in the neonatal population. ACE inhibitors promote systemic vasodilation and reverse remodeling by blocking ACE, angiotensin converting enzyme, which converts angiotensin 1 into angiotensin 2. In infants less than 4 months, it's important to be extra cautious in their use as they are particularly susceptible to acute kidney injury and hyperkalemia. And many of us will often choose captopril for first use in infants since it has a shorter half-life. This is one of the novel heart failure medications, so ARNI, angiotensin receptor neprilysin inhibitor. The brand name is Entresto, and this is a combination drug of sacubitril valsartan. So sacubitril is a neprilysin inhibitor, which is a type of medication that blocks the enzyme neprilysin, which is responsible for breaking down the beneficial natriuretic peptides, so that's BNP, and other vasoactive peptides. And by inhibiting neprilysin, these drugs help increase levels of natriuretic peptides, which leads to vasodilation, reduced blood pressure, decreased fluid retention, and improved cardiac function. And then the other drug in Entresto is an ARB, so similar to an ACE inhibitor in that it inhibits vasoconstriction and improves blood pressure control. And in the adult studies, they found that ARNIs were superior to ACE inhibitors in terms of heart failure outcomes. There was a randomized controlled trial done by Dr. Shaddy that was published in 2024, and this was a placebo double-blinded RCT multi-center with 375 children. Looking at how many infants were in this group, the youngest age cohort that they described was 1 month to 2 years, so it did include some infants, 31 of which received Entresto and 39 were randomized to enalapril. And the overall findings of this pediatric RCT was that there was no difference between groups, which was unfortunate that it wasn't a positive study, but I still think it's a very useful study because they were able to show that both groups improved, meaning patients on enalapril and Entresto got better. So these are good drugs for treating heart failure in infants and children. In patients requiring IV inotropic support, while dopamine is the most studied IV inotrope in the NICU, for patients with chronic heart failure being considered for heart transplantation, the typical inotrope of choice is often milrinone, which leads to increased intracellular calcium with both inotropic and lusitropic properties, meaning relaxation of the ventricle, as well as systemic and pulmonary vasodilation without a net increase in myocardial oxygen demand. In neonates, there was some animal data that questioned the maturity of phosphodiesterase type 3 receptors in the first few days of life, but small single center studies with infants on milrinone found an increase in splenic and cerebral Doppler flow as early as 12 hours of life. The main thing to monitor is for hypotension and the potential for thrombocytopenia, though that is less common. And clearance also depends on renal function and gestational or postnatal age. Milrinone works by ultimately increasing intracellular calcium, and it's important to remember that neonates have inadequate calcium stores and less mature sarcoplasmic reticulum. A normal ionized calcium level is important for myocyte contractility, and some infants respond really well to continuous calcium infusions. Patients with end-stage heart failure that is refractory to medical management should be considered for mechanical support. If a patient needs respiratory support as well, then they would require ECMO. If their lungs are okay and they require mechanical support for a failing ventricle, then a ventricular assist device should be considered. VADs remove blood from the ventricle and then pump it back into the circulation. If the pump supports the left ventricle, they are called LVADs, right ventricle RVADs. If there's a pump on the right and the left, it's called a BiVAD. And some of our congenital heart disease patients have single ventricle support, and we call them SVADs. In the NICU, VADs are paracorporeal, meaning the blood is drawn out of the body into an external pump and then pumped back into the body. In older children and adults, there are intracorporeal devices that patients can actually be discharged home on, though unfortunately we do not have small devices yet for the NICU population. You may have heard of one in development, which is known as the Jarvik 2015, that is under trial, though the smallest patient that can be enrolled right now is 8 kilos. The Berlin heart is FDA approved for pediatrics and comes in different sizes. The smallest is a 10 cc pump. It's an example of a pulsatile VAD, and it's pneumatically driven, pulling blood out of the ventricle and then pumping it back into the aorta. The cannulas are very secure, so patients are able to rehab well on these devices. For our infants, once cannulas are well healed, we allow them to do tummy time, for example. There are also paracorporeal continuous flow devices, and in the NICU, the smallest option is the PediMag, which can flow up to 1.5 liters per minute. And they were intended for short-term use, though many centers will attach the durable Berlin cannulas to a PediMag to support patients for longer term. So why use a ventricular assist device? We use a VAD to support a failing ventricle and use the following terminology when describing the goals and intentions of care. Either a VAD is bridge to transplant. In the case of, for example, cardiomyopathy, a VAD is bridge to recovery, which an example would be myocarditis. destination therapy, which is not really relevant in the NICU, but just so you know, in the adult world, the majority of VADs that are implanted are for destination or chronic therapy, meaning they are not otherwise being considered for transplant, and that's just their treatment for their heart failures to stay on a VAD. And then we'll also use the term as bridge to decision, so sometimes we don't know if there's going to be recovery, if they're going to need a transplant, and so they may get a VAD as we're getting a better sense of the clinical trajectory. Or we might say as a bridge to a bridge. So for example, ECMO may be a bridge to a VAD. So when do we implant VADs? There was a consensus statement that was published in the Journal of Heart and Lung Transplant in 2021, and they stressed that VAD implantation should be considered in patients with end-stage heart failure, ideally before significant end organ dysfunction or clinical deterioration. There is significant variability between centers, however, in terms of approach, the devices used, and threshold for implant. And the threshold for intervention has evolved over time as devices have improved and our management strategies while on device have evolved. Historically, for example, the stroke risk on the Berlin heart was 30%, but now with the use of bivalirudin as the anticoagulation agent of choice and some various multi-center quality improvement initiatives, that stroke rate has decreased to around 12%. This flow diagram provides a framework for device selection in pediatrics. Broadly, MCS implantation should be considered when the overall potential survival and quality of life benefits of mechanical support outweigh the risks of device compared with continual medical management and aligns with the family and patient's goals of care. In patients with critical cardiogenic shock in need of full cardiopulmonary support, then VA ECMO is appropriate. In patients in need of cardiac support only, the next branch point in decision making is the anticipated duration of support required. Do they need short-term support on the order of days to weeks, or long-term support for months to even years? Then the device selected varies by patient size, flow requirements, and then for the intracorporeal devices, the anticipated device fit. For infants or small children, our options are generally ECMO, PediMags, or Berlins. Whereas for older children, you can see there's a lot more devices that we can consider. So how do infants fare if they require VAD support for end-stage heart failure? There is another PEDS VAD registry called ACTION, the Advanced Cardiac Therapies Improving Outcomes Network. They do a lot of quality improvement work as well and a lot of education. And they published a registry report looking at all pediatric VAD implants between 2018 and 2023, which included over 1,000 patients, and there were 442 who were less than a year in the data, and of those, 178 were less than 5 kilos. And pretty consistently, we know that infants tend to fare the worst out of all age groups, with a 1-year survival of 79% and tend to have a higher incidence of stroke at 20%. A lot of this is related to both recipient factors, certainly being smaller is more challenging to support, and also relates to device factors as well, given that small patients require paracorporeal devices, which are associated with worse outcomes, whereas the intracorporeal devices have better hemocompatibility profiles and have lower stroke risks associated with them. These are just a few more Kaplan-Meier survival curves looking at survival on VAD support. Again, these slides are actually for all ages, but the key concepts in here are in this top picture. It is looking at the different device types, and we know that the intracorporeal devices do better than the paracorporeal devices, and among the paracorporeal devices, patients who are on a paracorporeal pulsatile device like the Berlin heart tend to do better than those on continuous flow devices, although this is difficult to tease out a little bit because many times the sicker patients are put on a continuous flow device, so there may be some recipient factors that are influencing some of those outcomes as well. The curve below that is looking at the PDMAX profile at time of implant, and this is showing that we know that sicker patients do worse in terms of survival on VAD support. And then this Kaplan-Meier curve is showing that cardiomyopathy patients do better than congenital heart disease patients. So when should we consider implant? We performed a survey of pediatric VAD physicians and CV surgeons to try and understand their clinical decision making in the current era with regards to timing of VAD implantation in pediatrics. One of the series of clinical vignettes was about a 4-month-old, 5-kilo baby with dilated cardiomyopathy. And in a baby that was inotrope dependent but otherwise stable on room air, 14% of respondents said they would offer VAD support, whereas if they were intubated, 78% would offer VAD support in that scenario. And if they were intubated with worsening end organ function, so sliding on inotropes, 92% would offer VAD support. As outcomes continue to improve, we're seeing that VADs are being increasingly used as a bridge to transplant. And in infants, you can see that here in green, that over 35% of infants with dilated cardiomyopathy are now bridged to transplant from VAD support. Pictures speak 1,000 words. Here's a photo of one of our 5-kilo babies with decompensated heart failure who was intubated on inotropic support when he underwent VAD as bridge to transplant. And this is what he looked like on the Berlin heart. He was able to gain weight, practice tummy time, and learn to sit independently while he waited months for a donor heart. And because he went into transplant in great shape, he recovered very quickly and was discharged home on post-op day 12. Briefly about transplant in general. In the US, we do around 500 transplants a year, and of those, over a quarter are in infants. And infants fare the best out of any age group, with a median survival of 24.5 years. This is likely attributable to their naive immune system, which likely offers a unique window of opportunity for successful transplantation. So, in summary, the etiology of heart failure in neonates is diverse and requires a thorough diagnostic approach to guide treatment. There's a paucity of data in our field, and we have extrapolated much of our management from adult data. Improvements in managing patients on VAD support has led to improved outcomes. And for patients undergoing infant heart transplantation, median graft survival in this age group surpasses all others, and presumably and hopefully our outcomes of infants transplanted today will fare even better. Thank you very much.